to say something different is not always easy. Sir Juris Koning took decades to convince that the retinal hole causes detachment and not vice versa. I appreciate all those surgeons who have put their reports in finding out capsular axis, divide and conquer, hold and chop and chop technique, and they are followed universally. I have a different technique to suggest. This technique is what I call this hold, crush and chop. Hold the nucleus, crush it and chop. Now I will not describe the routine stuff here. The anesthesia part first. Usually anesthesia is topical or peribulbar. I suggest an anterior peribulbar anesthesia, which I mean I use only 26 gauge needle and half inch in length, which goes here and about 1 cc injected here at the equatorial area, half inch on that. Then you may add 1 cc here. Now this anesthesia will block and produce even facial effect, facial block effect, and whole area is anesthetized. While withdrawing the needle from here or here, we just inject a little bit subconjunctivally so that the eyeball is also totally anesthetized and no more anesthesia is required. Of course, you can add other anesthesia if required in some cases. Now, staining of the capsule. I stain capsule little differently than the other people. That is, I stain as if a painter stains a wall, like that. With the needle, I stain the capsule and it gets a very regular, nice staining of the capsule with very little amount of prep blue. Now, principles of my technique. Usually it is good for in a hard cataract because it's easy to hold. The soft cataract may be difficult to hold. So suction is maybe more important there than the my technique. So what I do is after the cracking the nucleus, I pass from the periphery to the center one special silky type of hook which I have done behind the nuclear half and one in front of the nuclear half, and take out the nuclear half out of the capsular block slowly. Then I again inject viscoelastic and then I pass one my chopper which is blunt like sensitive hook, and one in front, one behind, hold it, crush it and chop. That's what I do. A nuclear half can be divided in 3 and 4 pieces, and these 3 and 4 pieces require very little phaco power. Against the phaco probe also, you can crush the nuclear piece. Its requirement of the phaco power is reduced to 1/3. So all this time, slowly all the pieces are gone. Same is repeated for the other half. And you have to remember that while you do chopping, the whole force may not be diverted towards the procedure, but it the nucleus you have to hold with a high suction, which is not required in this case, because one sensitive type of chopper behind one nucleus, the whole force is between the two choppers, and then you will be surprised that very little force is required to crush and chop, and it is very easy even for the beginner. There is no positive pressure of hypo power, so even if there is a rain, you won't be dropping the nucleus. So this technique, you can use it in capsular bag. You have to be careful that you don't engage any capsular part, or at the pupillary level, or in the anterior chamber. Now you have to take special care for endothelium, so that it does not, you don't touch the endothelium or brush the nuclear piece against endothelium. Advantages of this special technique is, in small and rigid pupils, you have to use iriso. But most of the times I can get away without them, and I just do the cracking as usual by just using the lens rotator and doing the sculpting, and then if you get two pieces, then you go behind and take it out of the capsular bag. Now this avoids a blind procedure which otherwise you will have to do behind the pupil, which is constricted. So if the pupil is dilated with the hooks, then the normal pupil is disturbed, and particularly this may not be good for multifocal lenses. Then once you have taken the nuclear half in the anterior chamber, again you can make the pieces thin, and you are very, very safe. Then hard cataract, it's very important that the hard cataracts are done within very short time. This technique helps to reduce the photo time as well as operation time. And hard, black, rubbery cataracts are the real indications for this technique. Now, hypermature cataract, where the axis has gone haywire outside, because it is there is so much of a back pressure that it might go out. Here also, you can go behind, take it in the anterior chamber and do the procedure without any problem. Very deep AC is again a problem, you have to go very deep. Here also, you go behind, once you have cracked the nucleus, you go behind and take it in the AC. Now the deep AC is an advantage because you get a lot of space to operate. High vitreous pressure and shallow AC is also a good for this technique. Means otherwise a high vitreous pressure means there is likelihood of posterior capsular rent, which can be avoided with this, because you are doing when there is no positive pressure of this and you are taken out into the whole thing. And now in a case of, if you find a PC red, then you don't get scared. Just do pass one hook behind, one hook after putting along, push the vitreous back and take the piece anteriorly and do the backward splitation where there is no rent. And when if the vitreous is coming up, again put the along, push back the vitreous. So vitrectomy is avoided. In posterior polar cataract, what I suggest is a means with a hydrodelimitation, and then take out the delimited portion with the two hooks anteriorly, and then what remains is the epinucleus and cortex. So start from tail of clock and first take out the peripheral and then go to the central portion which is attached. Now this is where attached portion there could be a PC range, but then it occurs at the last stage where it doesn't matter much.